Perfect. Thank you. Hi, everyone. Welcome. Thank you for joining the Family Centered Care Task Force webinar. We started organizing this webinar series last year this month to create an educational learning community about the importance of family inclusion. So we had great successes so far, and this is our 7th webinar. And thank you for joining. And next slide. You are familiar with this slide about our core team. I am Dr. Malathi Balasundaram, neonatologist and clinical associate professor at Stanford, and one of the task force co-chairs. And Dr. Colby Day is a neonatologist and assistant professor at University of Rochester, and she is another task force co-chair. And Carolyn is our task force program manager, and she helps us keep on track. And you have noticed that we have a new core member on our team. We are honored to have Kira Sorrells, founder and executive director of a NICU Parent Network, as one of the task force co-chairs. This shows a perfect example of the true collaboration of healthcare partners and family partners. And we appreciate your expert insights, Kira. Thank you for joining our core team. And next slide. So this month webinar agenda is listed here, and I will start with a brief FCC task force update and hand it over to Colby to introduce the first session speakers and moderate the question and answer, and followed by Kira Sorrells introducing the second session family partner speakers and moderating the question and answer. I will come back and share some closing thoughts. And next slide. This slide shows our organizational partners. So it expands monthly, and we truly appreciate everyone's partnership in this critical initiative. Recently, we are partnering with the NAN, National Association of Neonatal Nurses, which supports our task force and helps promote our work to reach the nursing staff. And thank you everyone for your partnership. Next slide. And also, we want to acknowledge our supporters, Genentech and Prolacta Bioscience, for their support for phase 3 small group QI work, and KSE for the Gravens Conference luncheon discussion. Thank you. Next slide. So besides the educational webinars, so we have 5 small groups of 34 centers regularly meet and work on implementing family-centered care and family partnership council in their local units. And this slide lists their next meeting dates, so to keep the momentum going. So they regularly meet and then discuss the barriers and implementation strategy. And I just wanted to thank the small group leaders for keeping this going, and thank you. And next slide, please. So the FCC task force has 3 committees so far, which are listed here. The Communication and Marketing Committee is led by Dr. Daphna Barbova, and the Newsletter Committee is led by Dr. Vargabi Gee, and Dr. Kerry Makau leads the brand new Advocacy Committee. Next slide. So I'm excited to invite our amazing new family and healthcare partners to our executive council. And Alex Zavala is a NICU dad and a strong FCC advocate who founded the NICU Dad online platform and sharing the resources for NICU dads. And next we have Jamile Jackson, it's a NICU mom and inventor of Zacky Zack to do the longer and safer skin-to-skin care, and who founded the International Kangaroo Care Awareness Day and celebrated globally on May 15th. And then next, we have Dr. Mia Malcolm is a NICU mom and program manager for equitable patient family-centered care at St. Louis Children's Hospital and strong DEI advocate. If you attended the Gravens Conference, you must hear our saying, don't boil the ocean, start with the pot. And so I take that code and start something small and go from there. And in addition to 3 family partners, we have 2 amazing healthcare partners, and Luan Jones, a practicing neonatal nurse practitioner and NAN secretary and treasurer, and a strong FCC advocate. And when we have a Nicole Nyberg is the NICU mom and practicing nurse practitioner and founder of the Empowering NICU Parent organization to support the NICU families. Thank you all for joining the Task Force Executive Council and bringing in diverse perspective. Thank you. And next slide. So this brings us to our Executive Council of 19 family partners, including Kira, and 20, next slide, please, and 20 healthcare partners, including Colby and me. And thank you for everyone for supporting your work. Next slide. Just a quick reminder about our website. All webinar recordings are posted on our website, and sharing our FCC related articles and newsletters under resources. So check it out and feel free to share with your staff. Next slide. I am excited to share last month we had the presence of FCC at the PAS Scientific Society. 4 family partners, and I shared the family-centered care, what's next. And we had a concurrent clinical trial sessions happen at the same time, but still we had a close to 50 participants and had a great discussion after the talk. And I just want to thank Dr. Jochen Profit for organizing and moderating the session. It's just the beginning of the conversation. Next slide. Now I will hand it over to Colby to introduce the speakers.
Thank you. Hey, everyone. I'm excited to introduce you to our first 2 speakers today. Molly Faust-Wylie is a NICU parent and a NICU family program manager at Beth Israel Deaconess Medical Center in Boston. As a direct result of her experience both on bed rest for 6 weeks with her son to being in the NICU with her premature infant, Molly believes in the importance of community support and shared experience for NICU families. Molly provides a unique parent voice on multidisciplinary teams with the aim of improving the overall experience of families with infants in the hospital. She's the chair of the Family Advisory Leadership Committee for the Neonatal Quality Improvement Collaborative of Massachusetts Family Engagement Collaborative, and serves as a board advisor to Project Sweet Peas, a national nonprofit that supports families of hospitalized infants and those who've been affected by pregnancy and infant loss. I'd also like to introduce Dr. Meg Parker, who is an associate professor in the Department of Pediatrics at the Boston University School of Medicine and a clinical neonatologist, health services researcher, and newborn research director at Boston Medical Center. Dr. Parker's work focuses on racial and ethnic disparities in infant care practices of vulnerable populations. She's also very engaged in collaborative quality improvement and implementation science. She is the Associate Director of the Neonatal Quality Improvement Collaborative and supports statewide initiatives in several states. So welcome to Dr. Parker and Molly.
Thank you. Thanks for having us. I'm going to share my screen. Give me 1 second.
Thanks, Molly. Great to see everybody. Okay, I think you guys, thank you so much for inviting us. I think how things are going to go is there's certain parts I'm going to do and then hand it over to Molly, and we're going to kind of go back and forth. Okay, so I'll start. So next slide. Molly's helping me. All right, so it's super exciting to be to talk with everybody. I actually really admire so many people on this webinar, and it's a real honor for me to be able to speak and share our story with you. We really hope you provide us some feedback too, because again, it's a team process to try to improve in this space as best as we can. And I'm sure Molly would agree on that one.
I do.
Yeah. So we just are kind of in wrapping up phases of our multi-site quality improvement family engagement project in Massachusetts, and we wanted to share with you about that. So just a tiny bit of orientation to this project. In Massachusetts, in our Perinatal Quality Collaborative, we previously had been doing 2 different collaboratives, a breastfeeding-oriented project and a safe sleep project. And in both of those, we actually found improvements in the process measures and outcomes in those. We were very happy about that. But we realized we were kind of hitting a wall in both of these projects about ways to further reach improvements. And through a lot of our interventions and work together as a state, we realized that an antecedent factor that played into improvements in breastfeeding and safe sleep provision was actually family engagement in care, and in particular, a focus on health equity. So this is what led us to launch this next statewide project. So next slide.
Oh, oh no, there we go.
Okay, so just one point to kind of hit this home for our breastfeeding project, we made a lot of improvements, as you can see, especially in the first part of our hospitalization. But one thing that we really realized as the project went on across the state was that we were seeing racial and ethnic disparities in receipt of breastfeeding support later on in the hospitalization. And this led us actually to do some qualitative work with families. And we realized in that work, again, there was huge barriers related to transportation, to visitation policies in the NICU, with siblings not always being able to come, food access, things of that nature. So these adverse social determinants of health and social supports were tremendous barriers seen particularly by families of color. And we also ended up doing some practice surveys about family engagement processes between different NICUs, and we found tremendous variation. So these were factors that also led us to do our family engagement project. So this is us. So we launched it. This is some of our leadership team members, and we'll talk about our group, but I was the main lead. And then we have a bunch of other faculty and family leaders in our group, Molly being our #1 family advocate that partnered with me through the project. So the primary drivers are just going to kind of happy to provide more details on the project, and we have things on our website. But some of our, we spent a lot of time deciding what to focus on. And as this group knows, family engagement and care is this very broad subject matter. There are sort of aspects related to the care itself, ways we can involve families in the care. There's sort of structural supports related to helping families be involved with sort of making PFACs, for example, or family members on QI teams. So we spent a lot of time deciding what to do. And in our project, we ended up focusing on these primary drivers. So first was about adequate and timely communication, and we had a big emphasis on equity by language status, comprehensive social supports, participation in hands-on care, and then discharge planning. Next slide. And again, this is just sort of showing our key driver diagram and our potential change concepts, and we collected data on those key drivers. Next slide. So what we thought we would share with you is a lot of times people want to know, like, oh, what were the actual interventions that teams did, and what are sort of ideas you could potentially bring back to your own hospital teams sooner rather than later. So we wanted to share just a small smattering of some of the PDSA cycles that our teams worked on. So first, we'll share a few that are related to that first key driver, which was on communication. Okay, so a big thing multiple teams worked on was actually reducing the time to the first family meeting. So our goal as a state was to try to improve having the first family meeting to orient families to the NICU occur within 7 days of admission. Some hospitals wanted to make that even earlier. They made that goal within 48 hours or within 72 hours. Some teams focused particularly on trying to make sure their family meetings for limited English proficient or LEP families happened equitably or equally to the English speakers. And some people really focused on like sort of the process of planning them and having them occur. Some other things people did is they had like these triggers to plan the meetings, triggers to make sure interpreters were called. So just want to share those with you. Another team worked a ton on not just making sure the meeting happened, but also trying to improve like the quality of the meeting itself. And in one of those teams really focused on wanting to ask the family their perspective about what topics should be covered in that meeting. So that was a team, actually it was Beth Israel, and they sort of worked on this concept of preparing families for the first family update and asking families their perspectives. Other teams you can see, again, worked on standardizing the content and consistency, because you can imagine many different provider types are covering different topics. So trying to, make sure that they are clear about that piece. And then again, the interpretation part. Next slide. And just showing you, like, this is one of the run charts. We always want to highlight teams that make run charts because that's super important in quality improvement. This was the Tufts Level 3 NICU, and you can see they were working really hard on trying to improve family meetings within 72 hours of admission. And they made a big effort and saw a big improvement in that area. Next slide. Okay, so one of the other ones we just wanted to highlight in this overview talk here was on social supports for families. Next slide. And this one we wanted to highlight because it was very successful. This was done at the Boston Medical Center NICU, where they were really trying to integrate social determinants of health screening and referral systems into their NICU. As folks have been talking about this a lot now in kind of the national audience, this is something that's been routinely done in the outpatient space, but it's really coming to our inpatient space. And we know that doing social determinant screening and referral, it does require some modifications in the process to really fit the NICU environment. So this was one of the first projects that was launched. And this is an example of the screener that they used, but we've had subsequent teams use a lot of different screeners. Okay, and this was their run chart. Also just wanted to highlight that they, you can see they did no screening and then suddenly it really bumped up. So this was what they shared. And actually this was just published in Pediatrics in the last couple months by Gabby Cordova Ramos, and we can share that reference for you guys later. And as an aside, this project was so successful, some of our future funding has been focused on trying to expand social determinant cell screening referral into the NICU setting across all of the NICUs. And this year we're in year with 5 NICUs, and next year we're going to add an additional 5. Next slide. Oh my God, people like the control chart. I know, isn't it awesome, Jeff? So cool. Okay, so some overarching goals and activities. I'm sure you guys have used some of these techniques in your collaborative approaches and, you know, multi-site meetings and whatnot. But I just wanted to highlight what we feel have been some of the most influential things for us. The first was really bringing diverse family experiences to our attention. And Molly was actually instrumental in this. But some examples here, we actually had Alex come and talk really early on. And I don't know if he's on this call, but I tell you, that was like sort of eye-opening for so many of the teams. Like they had never really thought about the father's perspective. Another thing we did, which I actually highly recommend, is we recorded and interviewed Spanish-speaking families and specifically asked them about their aspects of communication. And then we developed like subtitles with an English below, and we presented that in some of our webinars. We also found that to be like really enlightening because people had like never thought about those perspectives or heard those testimonials before. So that was great. As you can see, and we alluded to, we emphasized health equity like every time. And it was a main goal of our project was to have equity in our outcomes according to race, ethnicity, and language. Another thing we did in our project, which was really, I think, different from our other perinatal quality collaborative work in the past, is we felt like social workers were really elevated in their role. And they were on all of our teams and often the team leads. And I think this is important because traditionally social workers are not like involved in our QI projects about respiratory management or CLABSI or something. And so I think that I have to ask their perspectives, but it was great to pull them into the QI framework too, and sort of help with the basic principles of QI and getting them involved. Next bullet point is about the flexibility in the selection. So even though family engagement is like the super broad topic and there's so much to work on within it, you know, we did hone it down to those key drivers. And even then I felt like we almost were too broad, but we felt like at the time, this is what our sites wanted. We wanted to answer to them, but I want to just sort of compare it to what just has been happening in the Florida Perinatal Quality Collaborative, where they focus specifically on skin to skin care. And as a result, they've really seen an increase in skin to skin care. And for us in our state, we actually have only seen more modest increases or not increases in some of our drivers. And I think it's because our teams are really sort of varied in what they've been chosen to work on. So that's just sort of like a strategic decision for any of you that want to work on a multi-site project. You know, number one, there's bandwidth issues. Like you can only work on certain things at certain times. Don't try to do it all. And number two is, there can be advantages or disadvantages to honing in on a more smaller topic. And then, of course, as we know, our whole project has occurred during the pandemic, which had impacts, I think, on our productivity, bandwidth, and data collection. But that is what it is. Last is we were very concrete in our decision to align with our Massachusetts Department of Public Health definitions of family engagement and all of the things they were focused on too. Okay, this is
Right.
turn it over to Molly.
Thanks,
Yeah.
Meg. All right, so I'm going to talk about engaging families, and really importantly, why engaging diverse families matters. So we have an understanding that diverse perspectives may contribute to reducing social disparities in care delivery, which, Meg talked about and is very much representative in our data. And we know that sharing all different types of family experiences provides an opportunity for improvement, which is why we really decided to focus on that in our collaborative. But diversity of QI teams should really optimally mirror the patients that are being cared for in a unit. And that can be really challenging. So we're going to talk a bit about that as the presentation goes on. But we do know that engaging these families reduces barriers between caregivers and staff, because we do know that there are a lot of differences between those who are providing care and those who are receiving care. Whether it's culturally, socially, we know that there are huge differences that we have to acknowledge and we have to work through. We also know that engaging families really validates and honors and prioritizes their lived experience. Having a child in the NICU, having a critically ill infant, those types of experiences change our families forever. And we know, we have an imprint and an opportunity to have an impact with them that will last a lifetime. So engaging them and making them feel like that experience is something we want to hear more on and we want to improve for others is really validating. And I think it's something that we really try and prioritize. And it also gives a voice to parents and caregivers who may not feel empowered. Not everybody is able to advocate for themselves at the bedside or feel comfortable speaking up, but giving them an opportunity through quality improvement work later after, they're sort of starting their healing journey after the NICU, once their child is maybe a little older. It really gives them an opportunity to share an experience in a way that they may not have been able to previously. So what kind of diversity are we talking about? I think it's important to acknowledge that certainly we're talking about race and ethnicity, but we're not just talking about that, right? We're talking about sexual orientation. We're talking about family structures. In Boston, we have a lot of multi-generational families who are cohabitating. We see a lot of families who have chosen family. Their family may be not just, the birth parent and the partner, it may be aunts, uncles, people like that. So we really want to make sure that we're thinking about who families are, in addition to gender, income level, physical or mental ability. We're learning so much about disability and parenting with disability in the NICU. We featured actually some of that pretty significantly in this collaborative, and I'm so grateful for my colleague, Nicole Lomerson, who may be on this call, I'm not sure, for her work highlighting that. Education level, simple things. One of the things that we realized is that some of the titles of some of the programs that we were running automatically, like, NICU 101, that references college level coursework, right? It seems like a no-brainer, but we don't think about it. And we were really grateful to have someone give that feedback. So we were able to make those changes. And then, of course, a challenge that we're all facing with language and access, those who have limited English proficiency or who don't speak any English, how can we engage those families and elevate their experiences? And how are we engaging them? I think that we all know, and I think certainly why we're here is because we understand the relationship that we're building with families. And you have to build trust over time. What starts in the NICU can last a lifetime. We have families that come back who have literally 30-year-old children. And they don't forget those people who cared for them while they were becoming a family. And I think that's really special. And I think that's something that makes the NICU the most unique place in most hospitals, is that we get front row seats to people starting their families. And that's a really important way to build trust, right? So NICU nurses and staff are a great source to provide suggestions as to what families might be the best fit to join these works, or families to stay in touch with who might be able to, to provide feedback later on. They may not be ready right now, but let's stay in touch with them and see. It seems kind of obvious, but reaching out from email and calls, building alumni groups. We have a huge alumni community at my hospital, and it's something that my colleagues and I work really hard to maintain. It's really, it's really difficult to figure out all the different ways to stay in touch with people, but again, it's an extension of that relationship building. And we know that, in this outreach and in this direct contact, it does take time. And some families may say they're really interested, but ultimately they may not be able to commit, or they may be able to commit a minimal amount of time, but we want to be as flexible as we can with them, right? Something that's an easy sort of low-hanging fruit is just to create a stay in touch document or create an online form. We just recently did a mailing at my hospital where we used a QR code. We sent out a large mailing, and we gave families who are in, we have a massive mailing list, an opportunity for them to tell us that they want to stay in touch digitally. It was a QR code, super simple, but it gives an opportunity for us to get their contact information, and then we can reach out to them to see where their interest is in getting involved. I think overall, many NICU families really want to be part of NICU quality improvement work. They really are grateful for their experiences, or they really have feedback about their experiences that could change things for the better for their future families. So I think it's really important to highlight that we need to be flexible with the extent of involvement. So, things like Zoom or email feedback. Something that we're really trying to work on is figuring out how to hold meetings during days or nights. We really want to be sure we're transparent in the ask. We're giving what the time commitment is. We're giving who else is involved, right? Being transparent about the multidisciplinary team they're going to be joining. The NICU is a tough place, and some of our interactions are not always great. So we want to make sure that whoever is going to be joining us knows who they might see. And if they had an interaction that may have been tender, or it's still tender, we give them an opportunity to have some control over it, right? We're not going to surprise them by, putting them in a room with someone who it may be really difficult for them to be with. We try and compensate whenever we can for time and expertise. We really want to make sure we're not taking advantage of anyone's trauma, right? We want to learn from families, but we also don't want them to just sit and, spill their guts. It's really hard. So we want to work together and have them view themselves as equal footing. Some ways that we can do that are providing parking, childcare, transportation, food, and, importantly, using interpreters to get the voices of those families who may not be able to communicate at the bedside with us an opportunity to share their stories in other ways. So we did, as part of our, QI collaborative, we reached out to all the, participating units to get a sense of the ways that families are involved currently with them. And as you can see, our baseline was pretty good. But we would love to see these numbers higher, right? Parents on advisory committees, parents on committees, any committees, subcommittees, parent-to-parent peer support. Do you have a peer support network in your unit? Do you have a parent-to-parent support post-discharge? What does that look like? Interestingly enough, it seems like that is sort of one of the ones that is higher. And then in terms of QI, when we looked at how many family members were involved in QI activity, you can really see like very few people are able to do this, right? This is hard, this is tough stuff. And we're hoping, some of the things that we're talking about today will really help you to invigorate that and to really give your families a seat at the table, because their experiences really will make meaningful change in our units. I know it will. And I just want to highlight the fact that despite the fact that we strongly encourage all of our teams and gave them all of these resources, it was really hard, and a real minority of families really are including families in their QI work. It's hard, it's tough stuff, but we got to stick with it because it's going to make real change. So Meg is going to go over our data now.
Yeah, so just wanted to give you guys a little snapshot. We have been collecting data for about 3 years. This has been very difficult of all the things with our families, our staffing crises and everything related to COVID. I really felt like, sometimes family engagement and QI was a lower priority for hospitals in that setting. And then even lower within that was doing our individual level data collection. So, say all that, I am very proud that we had 1, 2, 3, 4, 5, 6. We had seven or 8 hospitals that did collect data of the approximate, 10 to 12 hospitals that participated. And we overall had over 400 dyads in our data set. And how we did this is we collected data on any baby that stayed at least 2 weeks in the hospital at a level 3, or at least 1 week in the hospital at the level 2s. The reason we didn't do 2 weeks at the level 2s is because so many of them had a really short turnaround and they actually asked for it to be at least 1 week. But we felt like that was enough time where we should hopefully these family engagement practices that we're doing should really influence families' experience. Next slide. So I just want to show you some of the data. This is like, honestly, we're just going to show you literally like 4 slides and be happy to share with you our more complete data. In Massachusetts, we actually openly display hospital names in our national presentations like this one, we put it by code, but internally in our state, we're really open about how hospitals are performing compared to others. That's very important for us to learn from one another. And it is viewed as a positive way to collaborate. But this is an example, of course, of, the theme you're going to see here is a lot of our major drivers, the data on them, you're going to see this really wide variation by center. And this is, again, like highlighting this concept of quality improvement, that when you see big variation by center, it means that there's ways we can continue to learn from one another and improve. So this was our main outcome, looking at any multidisciplinary family meeting in the first 7 days. And you can see how varied that is across the sites. And what, we also looked at this according to race, ethnicity, and we also looked at it by language status. We actually didn't see a lot of differences in those, which is great. Next slide. Social work consult. This was better. I would say this was better across the board, that overall, we had a lot of social work consults in the first 7 days. That hospital 6 knows that they're different from one another. And that's something that they're continuing to work on as well here. Next slide. Okay, and then again, this is the unmet basic needs. This was another really core component of what we wanted to look at with respect to social supports. And you can see this was also really varied across the different NICUs. Next slide. And this is just one of our run charts over time that we wanted to highlight that did show some great improvement, which was, change overall in unmet basic needs during the hospitalization. And this is, again, a huge effort that was first done by the Boston Medical Center, and other NICUs have started to get involved in this too.
So one of the amazing outcomes of all of this work and work with our team is the creation of NICU discharge videos. And we were so thrilled to secure funding from the AAP section on neonatal and perinatal medicine, as well as the Kellogg Foundation. So we understood the feedback from our families and from our colleagues that there was not a lot of discharge information available for families from the family perspective, right? There was tons of clinical information about discharge, but was that necessarily what our families were most anxious about? Not necessarily, right? They wanted to hear from each other about the experience of discharge. So we were so fortunate to get to put together these 10 videos. We have 5 in English and 5 in Spanish. There's all different types of families who are represented. We did a bunch of surveys and topics and interviews with families and providers to really drill down on what to distill those 5 different topics that we're going to be focusing on. The content was endorsed by the AP. We spent, it says just a year, but I don't think that's true, Meg. I think we might have spent 2 years working on this, to be honest. But they're live now. They're live, and we're so excited to share them. They're also on the aaphealthychildren.org site, and they're going to soon be on the this acronym, is it SNOPM? I always get it.
Oh, they're on the web. So a couple minor things to add here. So we're going to show you the videos, and we really hope that you all will help us with the dissemination. We had 2 different grants to help us make these videos, so we spent a lot of time and effort on them. So they're posted on the section on neonatal perinatal medicine website with a link there, and it links to like a YouTube video site with all of them.
The QR code. Take a look.
Yep.
If you use the QR code, you'll be able to get there. And they're all for families by families. So they only feature our NICU families, and they're in 2 languages, and they're free. Go spread them.
Yeah.
Get them out there, please. And I
Please
think,
do you want us to show? We wanted to show one. Can organizers tell us if we have time? Because we wanted to advertise. They take like 3 minutes, 3 to 5 minutes.
I sent Caroline a link to one of the shorter ones. Do we have time?
We can show one and then we can probably have about 5 minutes for Q&A.
Perfect.
So to
Thanks.
Betsy's point, I think your point is really well taken. To choose our topics, we surveyed listservs from family members, and that's actually how we ended up with our topics. We fully recognize that every aspect of the NICU experience is really important. And I actually think we should potentially make a whole nother set of these videos related to other experiences that families face. I do think these are predominantly focused on the preemie experience, and we made that choice predominantly based on the survey responses from families that we got about what they wanted to know. So anyway, but go ahead, why don't we show a video? I don't hear it, Molly.
I am not playing it. It is, I think Caroline is playing it from her
Oh,
computer.
okay, sorry.
Sorry, yeah, let me, 1 second, I'll try again.
Like other families, the NICU team helped us think through in advance what we would need to bring Maya home. As first-time parents, it was all new to us. So we felt fortunate that the nurses and the doctors helped guide us through everything we would need. Some of the supplies we got before she came home were diapers, wipes, rash cream, a bassinet, bottles, changing table, bottle warmer, pumping supplies, clothes, and pacifiers.
Sudden infant death syndrome, it can happen to any babies, even they born prematurely or they born term.
We got the bassinet ready in our bedroom and learned about the safe sleep from the NICU teams, including the ABCs of safe sleep, which is A is alone, B is on their backs, and C is in a crib. This is really important to reduce the risk of sudden infant death syndrome, or SIDS. We actually got 2 different bassinets so that we had a safe space to put her down to sleep, both in our living area so that she could be near us during the day as well. We make sure that all the adults who spent time with our baby were up to date on all their vaccines, such as the flu, COVID-19, and whooping cough.
And I would add that the respect of our support system was really important because Miller was so premature and we had to keep her in the bubble. People understood when we said, no, you can't come and visit, and no, you can't kind of be with her as much as they wanted to be for her own good. And I think that's something I would suggest to any parent that was in our scenario is stand up for Miller's or your baby's health. Nobody else is going to take care of them like you will. So just make sure that you're strong in that and you just do what's best for her, even though so many people are going to want to see your child because they are cute, but don't let your guard down because you're the only one that's really going to protect them when it comes down to it.
I know we're over time. I think we're done. Is there anything else, Molly?
No, just please share them far and wide. We want to get these out to as many NICU families as possible. I know that I would have loved and worked so hard to connect with other NICU families because I was terrified about going home and had no idea what I was going to do without the wonderful NICU staff. So we were so fortunate for these families to be a part of this project with us. It was truly an amazing collaboration and we're psyched about it. So please share them.
Thank you guys so much. It was just such a great presentation. I think it just goes to show that we never have enough time to talk about all of these topics. I think we have time to address one question. You've addressed several of them actually that were in the chat, but we had one in there asking if there was any correlation between the centers who made the most progress and involvement of families on their QI teams.
This would be an anecdotal response. Like I didn't look into that in close detail. So I would have said yes. I think that that's the case, but I haven't looked at that in like super granular detail. Yeah.
Might be an interesting thing to see if it improves engagement and whatnot. But thank you guys so much for this presentation. We'll be sure to distribute the videos. And I am going to turn things over to Kira.
Thank you so much. I am delighted to be able to introduce Lelis Vernon and Marybeth Fry. Lelis is a NICU mom with extensive work in quality improvement, research, and clinical guidelines. She's currently the family leader of the Florida Perinatal Quality Collaborative in the statewide family-centered care initiative. She is faculty family partner in Vermont Oxford Network, and she also collaborates with other healthcare entities such as the AAP, CPQCC, PCORI, Next Society, and the Department of Perinatal and Neonatal Medicine Research Lab at Stanford University. She's an author, an international speaker, and actively collaborates with the Pediatric Society in her home country of Argentina. Lelis recently graduated from Harvard Medical School postgraduate program on safety, quality, informatics, and leadership, where her capstone project was recognized as top 3 in her class. Fantastic. Marybeth Fry is the NICU Family Care Coordinator at Akron Children's Hospital in Akron, Ohio. In her role, she mentors and coordinates programming to support current NICU families. Additionally, she serves on a number of unit and hospital-based committees as the parent voice in quality improvement projects. Ms. Fry is Vermont Oxford Network faculty as the lead family partner of their NICU and iNICU collaboratives and experience-based co-design program. Thank you so much, Lelis and Marybeth. We are excited to hear about your presentation.
Great. So can you see my screen? Yeah.
Looks great.
So unfortunately, Marybeth is not available, so I'm gonna take the whole presentation, but I worked with her for many, many years in Vaughan as faculty. So I hope to do justice to her experience, and I think she's gonna pop in the chat later on. So great presentation, Meg and Molly. It's great to have friends and colleagues opening today's session. So I'm gonna take it to perhaps a different perspective. It's family engagement examples at a national level. And I'm gonna just do a very brief overlook of what's going on at a national level. And then we're gonna take some time for Q&As. But I wanted to exemplify here the very long road that families have to go through and take for being on one side of the isolate, landing in the NICU with an unexpected birth, and then being able to sit at the table, co-designing and the decision-making processes with the hospital. I hope everybody here on the clinical side appreciates how long of a road it is, how challenging it is, and how unique it is to have these families collaborating in the different venues where we do have a space and a place to collaborate with you. So I'm here because I am the mother of Bobby and Charlie. They were micropreemies, 25 weekers, 1 pound each. And they had twin-to-twin transfusion syndrome, and we stayed in the NICU for 4 months. And so I've been doing this for 15 years. And so while I talk, I know I have a lot of my friends in the group. So whoever wants to share their experience, please do so. So who are we and where is there we go. Who are we? So there are different kinds of families collaborating at a national level. For the most part, we are NICU graduate families. They are the Mollys and the Marybeths and the Kiras of the United States. We are families that have been able to put behind our experiences and have the courage to go back to the unit and partner with clinicians and mentor other families at the bedside. And we wear many, many, many hats. I'm gonna talk about that later on. So a lot of times I'm being asked, how many families does a PFAC has, or for how long do they serve? And I think that the word of the day is variation. A lot of teams allow families to come back to the unit to collaborate with them right after discharge. Some others make them wait 6 months, some others 1 year or 2 years. It really depends on the modality of each NICU. And then what makes a PFAC, right? How do we quantify it and how do we qualify it? Is there a guideline? Well, the Institute for Patient and Family Centered Care has some published guidelines. However, as I mentioned, there is a lot of variability in the interpretation of these guidelines. And so sometimes you will see that a PFAC is made up of one family that is consulting with the clinicians in NICU. And sometimes these PFACs have hundreds of families, as it was the case in the PFAC that I created in my NICU back in 2008. So hybrid partners, this is a new generation of partners. These are clinicians that then happen to have a NICU baby, or the other way around. These are families that have been so deeply impacted by their NICU experience that they go back to school and become NICU nurses or social workers or neonatologists. And now they can collaborate and really bring a unique perspective from both sides of the isolate. And then we have clinicians serving as advisors. We see that a lot in quality improvement, where the level of technicality is a little more elevated. So it is easy to put a clinician to check that box of the family. However, this is of course not recommendable from the family perspective. We would rather have the layman, the raw experience and the voices from our side, from our shoes, in terms of collaboration and contributions of the voice of the consumer when it comes to quality improvement and other engagements. Then we have community groups, and of course we have here Kira. She's the queen of community groups in the United States. I'm going to show you more later on. And then we have outsourcing to other entities. And these are very, very few entities, like the Mart of Dimes, for example. The modality of the Mart of Dimes, although their presence is very big in the country, the modality of the Mart of Dimes is very unique, because the families need to be employees of the hospital to then buy the program from the Mart of Dimes to then disperse it to the families in the NICU. So I think that those are very specific contracts. Hand to Hold, for example, from Texas, is also expanding their footprint throughout the NICUs in the country. But those are very really outsourcing, right? It's not an organic growth of a PFAC or a group of families from the NICU. It's actually other families being taken to collaborate in the unit. And so where are these families? And we are really everywhere. So first, I would say we are in the NICU. I included here a picture of myself and the twins going back for Christmas and giving gifts to the babies back in 2012, something like that. And as I mentioned, we wear many hats. We do anything from being part of the interview process for new staff for the NICU, mentoring programs, Nurse Week celebrations, donations to the families, transportation stipends for families that don't have access to the NICU. Desiree Bradley here has the Papas and Pizzas. Alex has the mentoring program in his unit. So we really do a lot. I have resources where I can show you the very, very long list of duties and expectations that families have in the NICU. And I think this is really incredible when you measure the level of skills that families bring from just having a NICU experience and elevating all that to doing all of this in the NICU. I think it's an extraordinary path. So kudos to everybody here that has been doing this. And we are also in the community, as I mentioned. Kira here has the NICU Parent Network, and this is a registry of some of the organizations that are part of the NPN. And these are organizations that have chosen to be part of this organism, but it does not mean that the list is limited to this, to these entities on the screen. It's actually, we have hundreds of entities, and they serve all gestational ages. They serve different birth complications. We have the trachea moms in Louisiana. So it's a wide variety of the nature of each community group is very unique. So I invite you to check it out in the NPN website. It's very interesting. Connect with them because they are an incredible resource when it comes to discharging families with specific conditions, and also to tap some of the gaps in care and really bridging disparities. When you really think about that, in South Florida, we have ICU Baby here on the screen, and the entity serves the 3 largest NICUs in South Florida. And during the pandemic, they were actually instrumental in providing transportation to the families that were not able to come to the unit. So really reach out to them. They are in your community, and they could be very, very useful. And then there is a new generation of family leaders. And these are the families that are serving at a state level. The NNP, the National Network of Perinatal Quality Committees, the NNPQC, which was housed at the CDC back in 2016, proposed a new structure for the leadership trio for each state PQC, where there was a clinical expert and a quality expert and a family representative. So some of us, Marybeth, I know, was serving for Ohio, and I currently serve in Florida. Molly serves in Massachusetts. So we have the possibility and the great opportunity to collaborate at a state level with statewide projects, right, that are going to impact the health that babies and families receive at a state level. And I think that is a great challenge and a great opportunity. Personally, I have to mention that for the FPQC, of course, in South Florida, we have a very diverse population. And so I'm personally very proud of the very diverse group of families that have been serving for the FPQC in the payer initiative that Colby here is a co-designer actually and co-creator of it. And now we are graduating. Actually, we have our last meeting tomorrow, and we are graduating to a new project, which is going to be about discharge management. And so bringing the voices of diverse populations is a real challenge, yes. But I think that the use of technology is helping us a lot. I don't know if you are all aware, but in Zoom, you have a tab that you can use, a plugin that you can use for translation and then transcription. So that can help you a lot. Of course, I'm from Argentina, so I'm fluent in Spanish, and I had the opportunity to chat one-on-one with Spanish-speaking families and capture their experiences personally. But we used Zoom during the pandemic, and we also use other modalities, whatever the family is comfortable sharing. It can be texts, it can be emails, it can be videos that they send to you, it can be FaceTime. There really are no limitations, I think, right now when it comes to reaching to those families. So I highly encourage everybody here that is considering putting the voice of the consumer in any quality improvement project to do so. And stay tuned, visit the Florida PQC. We have a lot of resources and a very interesting toolbox, also with bilingual videos in Spanish and English, and material in Creole as well. So quality improvement, and I was asked to really describe what the Vermont Oxford Network is. I have had the great honor to work with Vaughn for the past decade as faculty. So there are very distinct things about Vaughn, how Vaughn operates, and why this is not necessarily a QI entity. Vermont Oxford Network is a collaboration of NICUs. That means that the NICUs reach out to Vaughn to share their data. And so by doing so, what Vaughn does is divide the group of hundreds of NICUs into homerooms. And so different homerooms try to work on specific issues. Some may work on golden hour or pulmonary disease or nicotine enterocolitis, nutrition, brain care. So those are the homeworks, the homerooms, and we have 7 of them. And each homeroom has also 3 leaders, 1 clinical expert, 1 quality expert, and a family faculty. So in total, we are 7 faculty families in Vaughn. But all the families that work for Vaughn or in Vaughn or collaborate in quality improvement represent a specific NICU. So that means that the work of the families is very localized. It's very unit sensitive, right? It's very unit based. So they represent a group of families from a specific NICU. So Vaughn is not a community of families in quality improvement, but I invite anybody here, if anybody wants to make a community of families in quality improvements, please let us know. We have a lot of families that have experience on this, and we would love to have somewhere where to rest our skills and our experiences. I also want to mention that there is no specific formal training for quality improvement for families. In fact, Marybeth and I put together a very simple tool on how to speak quality improvement like a family partner. And it was very well received. It was back in February, I think. And so we are working on formalizing this and perhaps, creating something more elaborate to share with other families that are interested in quality improvement. But quality improvement is not for everybody. And I think that for the clinicians in the call, you must have witnessed this whenever you have a QI project and you are trying to fish for staff that is willing to come onto the project. It's a special language. And the way I see it, I think there are 2 very interesting things about quality improvement for the families now. There is one part that is very data heavy. Yes, there are a lot of numbers, there are a lot of run charts, as you might have seen in Meg's presentation. But there is also a big process side. And I think that that's where we are most instrumental in quality improvement. I think that's where our voices are resounding the most. We can debate how families interpret data and how we can give better input on the data that the units are collecting in a quality improvement project. But at the end of the day, I think that we are there to show clinicians and to share with them how those decisions impact families and their babies. And so I invite everybody to explore if they're interested in quality improvement. I personally love it. Once the bug hits you, it's something you can't escape. So some data. This is data is extracted from a poster presented by our friend and colleague Tisha Miller in 2019 in the poster fair at Vaughan. And I thought it was interesting because I get asked this a lot as well, the faculty at Vaughan is only micropremies. Well, no, that's not true. We have a very diverse admission and outcome base. In fact, we have full-term babies that had complications. And we also have diverse families when it comes to education. We have teachers, lawyers, PhDs. So really variation on that side. But we do have some similarities. And I think that this length of stay for more than 4 months in the NICU is testimony of how much exposure families had to the NICU dynamics and how long that NICU experience was. And also, we do have collectively, each of us, we have more than 10 years of experience working in quality improvement. And again, everybody, all of us started working at a unit base, and then were invited and to serve at a faculty level. And together we have over 15 publications. Some of them I'm gonna show you next. So families also collaborate in research. Of course, I'm very biased on this, but I just finished a call this morning with a very big healthcare authority. And they were asking how to put together a family panel for a research project. And I think that there is something very important here. Research per se is there is a model, right? You have a path to follow when you start a research project. And so what's interesting about working with families, or for us working with clinicians, is that for us, things are rather simple, right? Or things should be done in a specific way, and then everything would work. And that's not the way it really goes, right? So I think that communication is key when collaborating with families, and this could be said also for quality improvement, but mostly for research about to communicate with families about the technicalities of how research is being done. And also it is very important for clinicians to capture the voices of families and embed that in the final product. I added here 2 of the papers that I had the opportunity to collaborate in, and this was with the CPQCC. One publication is from this year, and the other publication is 2019, I think. But it was very interesting. I just hope that in the future, we have more co-authors that represent a wide array of voices, not just one family sitting in research. I think that is going to be a real challenge. So how I was asked this to put this in this presentation. So I think there are two how-tos. How do clinicians do it, and how do families do it? Well, how do units or clinicians partner with families? Well, how staff recruits families to do QI work in Vaughan. One of the main recruiting events is NICU reunions. The other one is really asking that family that has been very present or has been very engaging with the clinicians at the bedside. Who are those families that really make all those questions? Who are those families that you see them slowly graduating the way they relate with their babies, the way they relate with their clinicians, their level of comfort for being around the NICU. Just want to make, of course, everybody well aware that going back to the NICU can be re-traumatizing for a lot of the families. And I think that this comes from a place of lack of counseling, mentoring and mental health issues that I think it's a national issue, but it's a bigger issue, I think, in NICU. And so far, there are no remedies, there are no programs to address this need for families. So we have to be very cognizant of that although a family might look ready at the bedside, they might not necessarily be ready to come back to the unit to collaborate with you. How do you overcome barriers at a hospital administration and leadership buy-in? Well, in the universe of patient and family-centered care, we don't like the word buy-in. We would rather think that leaders are in the framework of needing and wanting to have families in the work they do to see better outcomes, better clinical outcomes for their patients. I would say, look at the evidence. There is overwhelming evidence that families are indeed a big asset for all types of collaborations at all levels of engagement in the hospital. And if not, reach out to some of the families that are in this call today, or that are in the MPN registry and the community organizations, or at Vaughan, and give us a call and we can help you out. So now this is for families. How do we, the families, overcome barriers? Because we do have barriers and there are many. So we have to collect data. And I know this is very foreign to us, the families, because we don't know anything about data. We don't know anything about how to translate our experiences into data points. And yet each NICU experience or any really interaction with a healthcare provider is rich in data points, good and bad. So I think that there is a big step for families to be able to move from the lived experience to translation of that into numbers and concrete and specific data. So how would that be done? For example, for the community organizations, I insist always on families, measure how many times you go to the hospital, how many hours you spend, how many families you see, what are the demographics of the families that you see, what are the types of questions that these families make to you, what do the families tell you that are their own barriers, how about the families that you do not see, and why don't you see them? Do they live far? Do they work full time? Do they have a broken down car that they are not able to take to the mechanic? And so I think that families in general are very open to other families, other peers at the bedside to relate their challenges. Take note of that. And yes, put it in a spreadsheet is a very simple step, but start making your experience at the bedside a data spreadsheet. And why do we need to collect data? Well, in the words of Edward Demings, one of the fathers of quality improvement, in God we trust, all of the rest bring the data. And so if you can't speak numbers, unfortunately, the ears of the leadership and other big entities that might be able to help you elevate the work that you are already doing at the bedside will not be there. So and I was also asked to explain why benchmarking family-centered care is important. Well, if we don't know where we're at, we don't know where we're going, or where the deficiencies are, or what things are not working for families. A lot of times, we, the families, might see that there are a lot of projects out there that hone in some clinical element or clinical outcome, right? But it's not necessarily something that the families are either in need or interested in. And so we need to do our part. And so I would challenge all the families to translate those experiences and all the work that you do in the NICU into data, and then, bundle it up, present it nice with a nice bow, and go to somebody, either in leadership or in some entity that can help you bring that up to your unit or to your community or to the state level and make a bigger impact, because you are already impacting lives, but show them what you're doing. So how to collect data? Yes, spreadsheets. And I am a huge fan of technology. I think I mentioned that before. There are a lot of new AI programs that can do this for you. You don't even have to do graphs. You can put your information and AI is going to put together some fancy graphs for you. So that there are a lot of tech helps. Now that's on the data side, but in the experience side, I know I've partnered here with Alex. We started looking at his experience with the dads. And so how do you design the path on how to put your collaboration all the way to the end to translating this into graphs and numbers and charts and whatnot. There is some strategy. So I think that's most of us here in this call are seasoned family leaders that can collaborate with peer-to-peer support. One of the big barriers that we have here is that we don't have national representation. There isn't, unlike the European panel, for example, or the South American panel, we do not have a community of NICU families at a national level. There is no registry. We are all working in different venues and at different times and levels, right? And then finally, when you have all that information, when you have some data, I really encourage everybody to reach out to different forums. There are many publications out there that are hungry to hear what you have to say. It doesn't need to be a research. It doesn't need to be a QR project. You just can share your view on a specific topic. You can share your opinion. But these are the ways that I see are needed right now to really make an impact on the work that is being done with families. If they don't hear from us, they will not know that we are here. And if they don't hear what we do and the impact that we have, there is no way that other entities are going to be able to grasp really the dimension of the work that we do. And so that is that. So if you have any questions, I see that the chat went from 5 to 37.
Yes, we do have a few questions, Lelis. Thank you so much for just a really great and informative presentation. There is a question about, is there a minimum number of family partners that should be involved in a specific QI initiative? I suspect every family experience is different, and we would continue learning the more families we added. But is there a target to shoot for? I feel like I remember reading something in the in a guideline somewhere that it should be half and half providers, half families. What is your take on that?
Well, it depends on what we are talking about, right? Whether it's QI or research. In research, most definitely, because there is a weight, right, of voices. And what I find many times in collaborating with clinicians is that your opinion, you can have a very strong opinion from a lived experience, and you can be very articulate. But if you have 3 clinicians debating something, you are going to be outnumbered. It's a numbers game at the end of the day. So I would really encourage in research specifically to really have 50-50 kind of voices. This is the case in the Next Society, for example, where there is really true partnership and collaboration, and it's really 50-50. And in quality improvement, I think it's a different animal. For quality improvement, you do have to have some QI skills to partner, and then so those families can collaborate with the team one-on-one in the design of a project, right? But then what I did for the Florida PQC, for example, because we don't have 20 families that are trained in quality improvement, for example, example, we did an ad hoc team. And so we have 20 families from very, very diverse populations and outcomes, and all of the diversity and equity that Molly presented actually in her presentation today. And so we have all those voices. So your QI collaborator needs to be able to grab all those experiences and be able to, plug all of that, all of those voices into your project when and where is more appropriate. And that's where the knowledge of the QI design is very important, I think.
And I love Molly made a great comment that having parents co-lead, so it's not just led by the clinicians or the researchers, but that the family partners are there in that leadership role as well, does a lot. I would think that that would also help to break down some barriers for families who may feel intimidated. I mean, I know I was extraordinarily intimidated, still get intimidated at times when I'm in a room of researchers and academics. So have you had that experience with families and how to help them overcome some of that timidity that may be present, or feeling like they're not quite good enough, or that kind of thing?
Well, when it comes to, myself, I wasn't.
No. Not you.
No, but I didn't walk in saying, oh, I'm here to do research. Of course, no, I didn't know anything either. But I think it's, if you're in that position, you should have enough psychological safety to ask enough questions to guide you better on how to be a better partner and how to be a better contributor to a specific project. But as I mentioned before, having an ad hoc and really looking, it was kind of pivoting one way or the other for me. It was kind of translating a lot of knowledge from the families to the clinicians and vice versa. So I would gather what was specifically what we were looking for in the families for our project and in the different steps of our project, and then turn around and look at the families and address that with the families and really, collate all those responses, and then go back to the clinicians and say, okay, here is our voices. I would survey the families a lot. A lot of families like anonymity, as you just mentioned, Kira, that they are not necessarily comfortable, being very open and very chatty. So a lot of anonymity. So yeah, I think that was for the most part the way we did it. I did a lot of qualitative analysis of our conversations. I love to transcribe the conversations and really go through and look at themes of what families are saying. I think they're very rich. All the stories are very, very rich.
Absolutely. Well, thank you so much, Lelis. I'm going to turn it over now to Malati to close out our webinar, but thank you so much.
Thank you, everyone. Thank you for all the speakers for your time, and it's amazing discussion. And I really enjoyed and I learned a lot, and I'm hoping to make some changes in my local unit. Thank you. And I just wanted to share this advocacy work. And I know I mentioned earlier, we have an advocacy committee. And so actually that committee put together this first advocacy effort. It's about parents and family caregivers are not visitors. So under the leadership of Dr. Carrie Maku and Dr. Colby Day and Nicole Neighbor, they actually put together this as a resolution and submitted to the AAP Annual Leadership Forum in March. So this all started with Nicole's presentation at the Gravens Conference about family visitation restriction during COVID. So we want to thank Dr. Munish Gupta, the current section of neonatal perinatal medicine chair, and Dr. Lily Lowe for past section chair for the review and sponsorship and getting approval from the section executive council. So we will share the next steps and the outcome to all the members, and as soon as we find out. And thank you for this great initiation. Next slide. So we have a great speakers lined up for the next rest of the year's webinars. So join the task force to receive calendar invites so we can have a great discussion about the family-centered care and family integrated care in the future webinars. Next slide, please. So I'm sad to announce this news that Carolyn is leaving, and she is no longer going to be a task force program manager starting June 1st. And she supported us during this past year's early phase of task force growth by organizing webinars and listserv and supporting small groups and countless behind the scenes activities, and kept me on track. And I'm really sad to let it go, and I'm happy for her that she plans to pursue a DNP in nurse midwifery at Oregon Health and Sciences University. You will be dearly missed, Caroline. Thank you for all your work, and you did amazing, and you supported us through this journey. Thank you and congratulations. Please join me wishing her best of luck. Everyone. Next slide, please. So Caroline didn't leave us alone without any support, and she recommended Morgan Kowalski. So we are lucky to find a program manager for our task force, and Morgan will be the new program manager for the FCC task force beginning in June. She is a proud NICU mom and being active and involved NICU family advisor in our local NICU and for several years, and also a family partner and small group leaders in our task force. And she will use her experience and expertise to serve the task force well. And she is thrilled to be part of the core team. And please join me welcoming Morgan. Next slide. So we will see you all in July webinar, and let us know if you have any questions, and follow us on Twitter. And don't forget to celebrate the Kangaroo Care Day, which is on May 15th. And thank you everyone for joining, and thanks for your time. Okay. See you all later. Bye.